All right, let's talk hyponatremia. We all see it, but some cases are just tough. So today, we're going to walk through 3 really challenging clinical scenarios. Think of this as a way to sharpen our skills, looking at this through the eyes of an endocrinologist.
And let's be clear, this isn't some rare exotic disorder. Hyponatremia is, by far, the most common electrolyte issue we deal with in the hospital. We're talking more than 15% of patients. So yeah, it's pretty much a daily part of the job for us.
So you gotta ask, right? If we see it all the time, why is it still such a headache? Well, the truth is, there are still some major gaps in how we diagnose and treat it. And getting this wrong? Well, it's not just about a lab value. It can have some really serious, even fatal consequences for our patients.
Okay, so the first thing you absolutely have to nail down is the timeline. Is this acute or chronic? Because the game plan is totally different. With acute hyponatremia, we're talking less than 48 hours. It's a race against the clock. The brain is swelling, and we've got to prevent cerebral edema. But with chronic cases, the brain's already adapted. The real danger there is actually us. If we correct that sodium too fast, we risk causing osmotic demyelination syndrome. 2 totally different beasts.
All right, let's get into our first case. This one is a true acute emergency, and it really highlights why you've got to keep your differential wide open, especially when things are hitting the fan.
So, picture this. A 47-year-old man comes in with a sudden onset of headache, he's vomiting, he's got vertigo. These aren't subtle signs. This is classic hyponatremic encephalopathy, and his sodium? A terrifying 112. This is a 5-alarm fire, and we need to think fast, and more importantly, think correctly.
Okay, let's look at the numbers. The severe hyponatremia is obvious, but check out the urine. The osmolality is up, the urine sodium is high. Now, I know what you're thinking. This screams SIAD, right? It's a classic picture. But here's the thing, you can't jump to that conclusion. It's a trap, and we've got to resist that knee-jerk reaction.
So, in this critical moment, what's the single most important lab you need to order right now to make sure you don't go down the wrong rabbit hole?
The answer is cortisol. And this right here is such a critical teaching point. SIAD is a diagnosis of exclusion. You have to rule out adrenal insufficiency first. It's the ultimate SIAD mimic, and if you miss it, the consequences can be absolutely devastating.
Okay, so knowing that adrenal insufficiency is on the table, what's our immediate game plan for treatment? How do we pull this patient back from the brink?
And here's how it played out. The cortisol came back critically low, so this was never SIADH at all. This was a full-blown adrenal crisis. Getting that diagnosis right changed everything. It meant we hit him with a 2-punch combo, 3% hypertonic saline for the brain edema and IV hydrocortisone to fix the root cause. That's what saved him.
So, case 1 was all about a dangerous mimic. Now let's pivot to a completely different kind of challenge. Case 2 is about the chronic dilemma. What do you do when the standard playbook just isn't working? I guarantee we've all seen this patient, a guy on carbamazepine for epilepsy with stubborn, chronic hyponatremia. We do what we're supposed to do. We put him on a fluid restriction, but his sodium barely budges, and frankly, he hates it. It's a classic, and honestly, really frustrating situation. Now, his labs, they look like textbook SIAD. But look here. We learned our lesson from case 1, right? We checked the cortisol, and it's totally normal. So this time, we can confidently say, yes, this is SIAD, and move on to thinking about SIAD-specific treatments.
So, fluid restriction is a bust. What's next? What's plan B when our go-to first-line therapy fails?
I like to think about this like a treatment ladder. Step 1, the bottom rung, is always fluid restriction. But if that doesn't work, or the patient just can't stick with it, you can't just stop there. You have to be ready to climb to the next rung. And that's where things like aquaretics, like urea, or the vasopressin antagonists, the vaptans, come into play. And for this patient, moving up that ladder was the key. He was started on a vaptan, and it worked beautifully. His sodium came all the way up to 141. This case is a perfect example of why we need to be comfortable with these second-line options. It's not just about a number, it's about quality of life. Okay, on to our final case. We've seen a mimic, we've seen a treatment failure. Now let's talk about something that's super common, often predictable, and frankly, preventable. We're talking about post-neurosurgery SIAD, a frequent flyer for hospital readmission if we're not on our game.
So, a woman post-op from neurosurgery comes back on day 9 with nausea, vomiting, and trouble walking.
The timing here is the huge red flag. Post-op SID loves to show up around day 7 to 10. And what's so dangerous about that? It often means the patient is already at home away from our immediate care.
And her labs just slam-dunked the diagnosis. Look at that urine osmolality, over 700. The urine sodium is through the roof. Meanwhile, her serum is dilute. I mean, it doesn't get more classic than this. Her kidneys are just stubbornly holding on to every last drop of free water.
So yeah, they were able to treat her and get her better. But that's not the real point, is it? The real question we should be asking ourselves is, did this have to happen at all? Could we have prevented it? And the answer is a resounding yes. This is all about being proactive, not reactive. It starts with us, maybe with a proactive fluid restriction from discharge through day 10. But even more important is patient education. We have to arm them with knowledge, teach them the symptoms, and give them one simple rule: drink to thirst, not ahead of it. That alone is incredibly powerful.
All right, so we've walked through 3 very different, very challenging cases. Let's boil it all down to the key takeaways you can bring to your next shift.
Here are the 4 big ones. Number 1, SIAD has a dangerous mimic. Always rule out adrenal insufficiency first. Number 2, acute severe hyponatremia is a neuroemergency. Treat it like one to save the brain. Number 3, don't get stuck on fluid restriction. Master that treatment ladder for chronic SIAD. And finally, number 4, be a psychic. Well, not really, but anticipate post-neurosurgery SIAD and educate your patients to prevent it.
And I'll leave you with this question to chew on. We know fluid restriction fails a lot, and we have these newer, really effective agents like the vaptans. So, should fluid restriction really be the automatic, universal first step for every single patient with SIAD? It's something we really need to think about as the tools we have to treat hyponatremia keep getting better.